In our last session, we talked about principles and products for chronic wound management, and we talked about guidelines for dressing selection. We focused on the importance of identifying and correcting etiologic factors, providing systemic support for wound healing, and providing topical therapy designed to move the wound rapidly through the inflammatory phase and then to support fibroblast activity during the proliferative phase. In this session, we're going to talk about management of refractory wounds. So let's start with the definition. A wound is said to be refractory or non-healing when there's been no measurable progress for 2 consecutive weeks despite appropriate management. Interestingly, when you talk to people around the world who are involved in wound care, approximately 30% of chronic wounds end up becoming refractory or failing to respond to initial therapy. So let's talk about, well, why would that happen? If you're doing everything right, why would the wound become refractory? And if the wound does become refractory, what do you do then? Does it make sense to just keep doing the same thing you were doing? So how do you move ahead? And how do you use science to guide your interventions? Now, at present, we believe that there are 4 major reasons that might explain a wound's failure to move ahead, to make progress toward healing. First of all, maybe we didn't get the etiologic factors identified correctly. Maybe we thought this was an arterial ulcer and it turns out to be a vasculitic ulcer, or maybe we thought we had the pressure completely eliminated, but when we go back and look carefully, we find that in reality, that patient is never completely off of the sacrococcygeal area. So the first thing we always have to look at is, have we accurately identified etiologic factors and have we effectively addressed etiologic factors? The second is maybe there's something going on systemically that prevents healing. Maybe the patient's not where he or she needs to be nutritionally. Maybe glycemic control is not at a level to support healing. Maybe the patient's on steroids and we forgot and we haven't even tried topical vitamin A. Maybe the patient's smoking and we don't realize it. So we've got to go back and look at our systemic factors. Helps to be very systematic and literally go down the list and check each thing to make sure that we've addressed all of the systemic factors. Then you want to look at your topical therapy and you want to look very critically at the wound bed to make sure that there's nothing going on topically like critical colonization, like biofilm formation that could explain the wound's failure to progress. But if we have accurately identified etiologic factors and effectively addressed those, if we have addressed all of the systemic factors and the patient is in a position to heal, if our topical therapy has been appropriate and we have a clean, moist wound bed, then the most likely reason for failure to heal is that there's some kind of imbalance in all of the regulatory factors at either the cellular or microscopic level. Now here's the problem. At this point in time, we don't have any good diagnostic studies. I cannot send a swab to the lab and label my slip non-healing wound. Please identify causative factors. There is work in progress to develop diagnostic tools to help us determine the reason for failure to heal, but we don't have them available to us at this point in time. So that means that when we start working with a wound, we start following the guidelines. We start with identifying and correcting etiologic factors, critically assessing and addressing systemic factors, providing topical therapy that will eliminate necrotic tissue, reduce bacterial loads, manage the exudate, maintain a clean, moist wound surface, and we monitor the wound. And as long as the wound is on track, we're like, okay. But if we have a wound that becomes refractory, becomes non-healing, since we don't have any easy way to check out what's going on at the regulatory level, at the cellular and microscopic level, we have to be detectives. And we have to stand back and look at each possible reason for failure to heal, rule that out, and then consider an active wound therapy to hopefully compensate for some of the problems going on at the cellular and microscopic level. So some of this we've already talked about. We've already said if you have a patient with a trunk wound and you're pretty sure that this wound is caused by pressure and or shear, and you've written appropriate orders for turning and positioning and support surface, go back and check. Make sure that they're on the right support surface. Make sure that the support surface is providing adequate support and conformability. Look very critically at their positioning program. If it's sacrococcygeal, you may find out that even though the staff is turning the patient frequently rolls back onto the side of the pressure ulcer, in which case you might need to change the patient to a higher level support surface, investigate use of different wedges, something to help offload that pressure ulcer. So go back, recheck. If it's a leg ulcer, you're going to reevaluate, make sure that you have accurately identified the etiologic factors. If there's any question as to whether or not you're on track with etiology, call someone else in to help you evaluate the wound. Consider a biopsy, and we'll come back to that. And finally, the last point. If you have a wound that becomes refractory, you have to always remember that there is the potential for chronic wounds to deteriorate into malignancy. It is never, ever wrong to request a biopsy, to obtain a biopsy, to rule out malignancy. Anytime that you have persistent hypertrophic granulation tissue, you need to remember that basal cell carcinoma can masquerade as hypertrophic granulation tissue. Anytime you have a wound with very abnormal appearing tissue in the wound bed and you're thinking to yourself, what is that? You should get a biopsy. So persistent hypertrophic granulation tissue, get a biopsy. Atypical unexplained tissue in the wound bed, get a biopsy. Unexplained deterioration, never wrong to get a biopsy. You would never want to miss a malignancy. And a biopsy is a very simple procedure done in the clinic at the bedside with just a little punch biopsy tool. It can be done by a dermatologist, by a plastic surgeon. If you're in advanced practice, you can do it. So never hesitate to ask for a biopsy. Back to systemic factors, that's checkpoint 2. So you want to look critically at your patient's nutritional status. Look at their weight. Has their weight stabilized? Are they gaining weight? What about their labs? Are their labs, their prealbumin, albumin trending down, stable, trending up? What about their intake? What about their appearance in general, hair, skin, mucous membranes? So look critically at nutritional status. If you have any questions about their nutritional status, enlist the assistance of the dietary department to help you make sure that that patient's where they need to be. Perfusion, obviously critical. We have been talking so far primarily about trunk wounds where perfusion is really not so much of an issue. We'll be talking in the next few classes about lower extremity wounds where perfusion can be a major issue. For patients with trunk wounds, the major things we have to watch for are edema, the impact of smoking, and the impact of positioning on the ulcer. And then finally, look at the patient's meds and make sure that the patient's not on steroids, not on high-dose non-steroidal anti-inflammatories, and not on chemotherapeutic agents. If the patient's on chemo, you're going to have to treat that wound as a maintenance wound until the patient's off chemo. If the patient's on high-dose nonsteroidals or on steroids, then you're going to consider topical vitamin A. Then look again at the wound bed. Make sure that all necrotic tissue has been eliminated. Make sure that there's no evidence of biofilm. You don't see that yellow adherent film or a gray adherent film. Make sure that your bacterial loads have been addressed. Many clinicians, if they have a wound that begins to plateau, will automatically switch that patient to an antimicrobial wound dressing, like a silver dressing, like PHMB, like Iodosorb or Iodoflex, like MediHoney. Any of your antimicrobial dressings would be appropriate to make sure that that's not what's interfering with wound healing. Make sure that exudate's been adequately controlled and that the surface has been protected and kept moist. And then finally, if you have a wound that's granulated to the surface and it's not epithelializing, recheck your wound edges. But let's say you've done all of those things. You have gone back through and you have meticulously assessed and addressed etiologic factors, systemic factors, and wound bed factors. Okay, now what? Now you know, or your detective work tells you, that almost definitely the wound is not healing because of something that is going on at the cellular or microscopic level. Either you have low levels of growth factors, you have high levels of inflammatory substances like MMPs, maybe you have a patient who's much older and they have a high percentage of senescent fibroblasts. There can be a number of things that are essentially out of whack at the cellular or microscopic level. We've already talked about the fact that we have no good way to diagnose the specific problem that's interfering with repair. Work is being done, but those tests are not yet available. Let me tell you about one specific test that is actually available in Europe but not yet available in North America. And that is a test to determine the levels of MMPs or inflammatory substances at the wound surface. It's a very simple point of care test. They had designed it to be similar to a pregnancy test so that you're actually looking for a color change on an indicator. Hopefully that will be available in North America within the next 1 to 2 years, but it's not available now. So we're going to focus on what you do with the knowledge you have at this point in time. So let's talk about your options. You have a wound, you follow the pathway, the wound progressed, stopped progressing. You've gone back through all of your management and you know that your management's been appropriate and that every correctable factor has been corrected. That leads you to strongly believe that something is wrong at the microscopic level. So now how do you proceed? You basically have the choice to continue what you're doing, which makes no sense because it's not working, or to change to another passive dressing, like to change from a foam to an alginate, or from an alginate to a hydrofiber, or from one foam to another foam. And that really makes no sense either, because you've already determined that you're managing exudate, maintaining a moist wound surface, managing your bacterial loads. So it's not going to help to go from one passive dressing to another. The third option is to switch the patient to what we call an active wound therapy. And that's the only option that makes sense. Active wound therapies, by definition, are therapies or products that are designed to actively stimulate the repair process. So you see in your handout, whether you're looking online or in your hard copy module, that once you decide to use an active wound therapy, typically you'll use that therapy for at least 2 weeks, no longer than 4 weeks if the wound is not responding well. So your trial period is usually 2 to 4 weeks. You do not use an active wound therapy until the wound is ready to move to the proliferative phase. You do not use active wound therapies on wounds with necrosis or on wounds with active signs and symptoms of infection or clear evidence of critical colonization. All of those things should have been addressed under topical therapy. Most of the time, if you have a wound that becomes refractory, it gets stuck at the junction between the inflammatory phase and the proliferative phase. We can usually move a wound through the inflammatory phase even if the patient's very compromised, because we can use antibiotics and antimicrobials to control bacteria. We can use instruments and enzymes and Dakins to eliminate necrotic tissue. So we can usually establish a clean wound bed, and we should always do that first. If I'm looking at using negative pressure wound therapy or another active wound therapy, I should be looking at a clean wound bed that is not granulated. Or I should be looking at a wound that had begun to granulate and has gotten stuck. I should not be looking at slough. I should not be looking at eschar. And I should not be looking at clinical evidence of infection. Okay, we've talked about what an active wound therapy is. On the slide, you see some examples. You also see that on your handout. And we're going to talk about the most commonly used active wound therapies. We're going to talk about what they do, when they might be appropriate, and considerations in using them. So the first one that we're going to talk about is growth factor therapy. There's one product on the market that provides exogenous growth factors, and that is Becaplermin, Becaplermin, Becaplermin gel, or Regranex. Now, we know the importance of growth factors to the repair process. We've already talked about the fact that growth factors and cytokines are the cellular or microscopic substances that actively attract cells to the wound bed, that stimulate cells to reproduce, and then direct cells to carry out specific activities associated with repair. So clearly, a wound is not going to heal if there are low levels of growth factors in the wound bed. Now, the first approach to providing topical growth factors was back in the 80s, where they actually drew the patient's blood, spun the blood down to isolate the platelets, treated the platelets to release the growth factors, then suspended the growth factors in fluid, and then that fluid was applied to the patient's wound bed. That product was known as Procure, and some of you may have heard of it. It's not on the market today. But the research done with Procure and the reports of improved healing in at-risk patients has stimulated ongoing research into use of growth factor therapy for non-healing wounds. So the company that developed Regranex gel did a very good job in their research. What they did was they took a group of diabetic patients with foot ulcers, and they selected diabetic patients with foot ulcers because of research showing that diabetics frequently have low levels of growth factors. Now, in the pre-trial phase, what they did was very comprehensive standard wound care. They made sure that the patient was not walking on the ulcer. They made sure that all necrotic tissue was eliminated. They aggressively treated any infection, and they focused on tight glycemic control. Now, when they did that, a large percentage of the wounds healed. Then they were left with this group of non-healing or refractory wounds, and those patients got Regranex, or this growth factor gel. Now, they actually used recombinant DNA technology to produce this product, so instead of having to draw the patient's blood, all they had to do was take this gel product off the shelf and apply it to the wound. What they found was that about 50 to 60% of the patients healed. So using growth factor therapy plus offloading plus tight glucose control plus aggressive management of infection resulted in very positive outcomes for over half of the patients. Now, there was still a group of patients who did not heal. So obviously there was something else going on with those patients. But it certainly demonstrated that topical growth factors can make the difference for some non-healing wounds. When would you think about using Regranix, the Caplerman gel? We'll go back to the group used for the research. So our data about the Caplerman or Regranix gel is that it can be effective for diabetic patients with non-healing foot ulcers, but only if used in combination with offloading, debridement of necrotic tissue, aggressive infection control, and tight glycemic control. So that's when you would think about using it. Now, I wanted to mention that there's a product out there called Autologel. The company is Cytomedics. They're using a process similar to the process used to develop Procurin. The patient's blood is drawn and spun down. And they produce what they call a platelet-rich gel. And then that gel is applied to the patient's wounds. Now, anecdotally, they have gotten very good results, and they do have some research studies available. More of their research studies are ongoing. At this point, this product is not covered by Medicare and Medicaid, but they are awaiting further data. So I put it in your handout, in the handout online, just so that you're aware of it, because you may find this product coming to market within the next couple of years. And I shouldn't say coming to market. It's already available in the marketplace. I should say you may see this product being added to the list of covered therapies within the next 1 to 2 years. Okay, so we talked about Autologel. Now we're going to talk about Oasis and Dermagraft under different categories because these are combination products. Oasis is a matrix dressing that also does release growth factors, but its primary function is provision of a scaffolding for cell migration, so it's actually included in a different category. Dermagraft is a product that can be placed into a non-healing wound that also provides a scaffolding for cell migration and fibroblast and growth factors. So we'll come back to that as well. But right now, when you think about growth factor therapy, I want you primarily to think about Regranix or the Caplerman gel and to think about Autologel. One last thing about the Caplerman is that it's very expensive. So one tube is about $600 at present. So that means we want to use it appropriately. We don't want to be putting it on wounds that aren't ready to move into the proliferative phase. We don't want to use it on wounds for which we have no data to support its use. Next, I'm going to talk about extracellular matrix products. Now, when we were talking about wound healing and factors that impact on wound healing, we talked about the importance of having a healthy wound bed. And we talked about the fact that cells have to be able to attach to the wound bed before they can begin to reproduce or before they can carry out activities that are critical to the repair process. One of my examples is if you were building a house and you wanted to do the wiring, but the house had not yet been framed. Well, how can you do wiring? Because there's nothing to attach the wiring to. How can you do ductwork? You have nothing to attach the ductwork to. So framing comes first because that provides the attachment sites for the wiring, for the plumbing, for the drywall, for everything. And the wound bed serves a similar function. So you need a healthy wound bed with what they call binding sites that allow the cells to attach so that they can then begin to reproduce and carry out critical functions involved in the repair process. But some of our patients have very poor quality wound beds. The wound bed is viable, but it's not a very healthy wound bed and it lacks the attachment sites needed by the cells. Can we see this? No. But if we have a wound that's clean, not infected, not necrotic, but we're not seeing granulation tissue formation, this is one potential cause. So we might think, well, let me use one of the products that has been developed for placement in the wound bed that will provide a temporary scaffolding that allows cells to migrate so that they can then reproduce and carry out critical functions like collagen synthesis. So you've got examples. Oops, I'm sorry. Your collagen dressings are one example of an extracellular matrix product. Oasis, which is derived from the submucosal layer of the pig intestine. And Oasis, if you have ever seen it, and I do not have a sample because it's very expensive, but it looks like parchment. It's a very thin dressing. And you cut it to fit the base of the wound. And remember, your wound bed should be viable. You place it against the wound surface. If the wound surface is somewhat dry, you want to moisten it so that it becomes very adherent to the base of the wound. So you've got collagen dressings, you've got Oasis, you've got Alloderm. There's a number of products out there that are designed to provide a temporary matrix for cell migration. So if you're concerned that the base of the wound is not providing the attachment sites needed by the fibroblasts and the keratinocytes, think about using a matrix product for at least 2 to 4 weeks. Now notice that Oasis can be reapplied weekly so that you continue to provide that scaffolding that allows cells to migrate, attach, and produce. I wanted to just mention Alloderm. It's not on the slide, but it is on your handout. This is a dermal matrix with no cells. It's actually derived from cadaver skin. Sometimes they use this in reconstruction of the abdominal wall because you're not going to get granulation tissue over abdominal organs. You have to have that scaffolding. Okay? You have to put something down that allows the fibroblast to migrate, attach, and produce collagen. So you may see Alloderm used in some complex wounds. You may see it used in reconstruction of abdominal walls. It will look kind of yellow-white and like a thin sheet, and then it should fairly rapidly turn pink-red as vessels grow into that sheet, into the scaffolding, and as fibroblasts migrate and begin to produce collagen. Now, one thing about Alloderm, and this is anecdotal, but I want to mention it because some of you will see this product used in some of your surgical patients, and that is if you're at all worried about high bacterial counts, you should use a silver dressing or some other antimicrobial dressing over the Alloderm. You want to make sure you keep the Alloderm moist until you have a nice healthy bed of granulation tissue. You would not use Dakins because there's some evidence that sodium hypochlorite can actually break down the Alloderm product. So until we know more, you just want to avoid its use. The next thing I want to talk about is MMP and activators. Now, we talked about MMPs when we talked about wound healing. And we talked about the fact that MMPs, or matrix metalloproteases, are the body's own enzymes, naturally occurring enzymes that are produced by cells in the wound bed that are tremendously beneficial during the inflammatory phase of wound healing, because what they do is help to break down necrotic tissue and help to create pathways in the tissue that facilitate white blood cell migration. In lab work done on healing and non-healing wounds, what they found is it's very normal and helpful to have high levels of MMPs during the inflammatory phase. As the wound moves out of the inflammatory phase and approaches the proliferative phase, the levels of MMPs usually come way down, signaling that the wound bed is now clean and we're moving to the proliferative phase, out of the inflammatory phase and into the proliferative phase. In non-healing wounds, they found that MMP levels frequently stay very high, indicating that there's continued production of these inflammatory mediators and these naturally occurring enzymes, which is not helpful as you're moving the wound toward the proliferative phase. So yes, you want enzymes, you want substances that attract white blood cells when you have necrotic tissue, when you have heavy bacterial loads. But as the necrotic tissue is eliminated and the bacterial loads are brought under control, you want to see a reduction in the enzymes, you want to see a reduction in the inflammatory mediators that are attracting white blood cells. If those levels stay high, that traps the wound in a persistent inflammatory cycle. Now, they have done very interesting work in the lab. A lot of this has been done at the University of Florida that has clearly demonstrated that a lot of wounds that fail to heal, and specifically venous ulcers that fail to heal, are indeed caught in that inflammatory loop with high levels of MMPs. And that's exactly why they've worked to develop a tool to identify high levels of MMP so we know what the problem is and we can intervene. We don't have that tool ready for us yet, so right now, again, we have to use our detective eyes in trying to determine, could this be the problem? So you think if you have high levels of MMPs, the real issue in terms of wound healing is that you have persistent inflammation. So if you have a wound bed that is clean, there's no evidence of biofilm, there's really no evidence of critical colonization, but you have persistent high volumes of exudate and failure to progress, then that could be high levels of MMPs. So clinically, what we might see is persistent high volume exudate and failure to granulate in a wound that is clean with no evidence of critical colonization. Now, we do have products available that will reduce the levels of MMPs and allow the wound to move out of the inflammatory phase and into the proliferative phase. At this point, we basically have two types of products. One is your ORC matrix products, and those, as you see on your handout, are like Promogran and Prisma by J&J or Puricol by Medline. And what they do, they're made of oxidized regenerated cellulose, which is the preferred food stuff for MMPs. MMPs would rather eat ORC than anything. So if you put a dressing onto the wound that is full of ORC, it's like a magnet to the MMPs, which pulls the MMPs away from the wound bed so that they're no longer interfering with the fibroblasts, they're no longer interfering with the repair process. It's kind of like if on one side of the room you had celery and cardboard, and on the other side of the room you had a dessert bar. Where is everyone going to go? To the dessert bar. So ORC is like a dessert bar for the MMPs. That means that if you have a wound that is not granulating and you suspect that one problem could be high levels of MMPs, it makes very good sense for your first intervention to be an ORC dressing like Prisma or Promogran or Puricol AG to reduce levels of MMPs. Now, the advantage of Prisma or Puricol AG is that it combines the ORC with silver so that you have two actions. You're reducing levels of MMPs and you're assuring that bacterial loads are maintained under control. So this is a very good general use product if you have a wound that appears to be at the end of the inflammatory phase but is failing to move ahead into the proliferative phase. Widely available, more expensive but not nearly as expensive as things like the Caproman or Oasis or Dermagraft or any of those things. So a reasonable first step for the average wound that's at the end of the inflammatory phase, not moving into the proliferative phase, is to think about an ORC silver product to reduce MMP levels, to maintain bacterial control. And the ones most widely used at present are Prisma or Puricol AG. Now, there's another approach to reducing levels of MMPs, and that's PHI technology, polyhydrogenated ionogens. And in this case, what you're doing is you're using a product that has a blend of metal ions suspended in a polyethylene glycol solution, and then that's applied to a dressing. And what that does is actually down-regulates the production of MMPs. So you can either use a product that reduces MMP production, or you can use a product that actively attracts MMPs and pulls them away from the wound bed, whatever you have available. And here I show you a non-healing venous wound, because that's what much of the research on MMP and activators and the impact of high levels of MMPs has actually been done on non-healing venous wounds. The next thing we're going to talk about is hyperbaric oxygen therapy. Now, hyperbaric oxygen therapy is a very specific active wound therapy, so it's not general use. Prisma is kind of like general use. The ones at the inflammatory phase and not moving ahead, that would be very appropriate, as would Puricol AG. In contrast, Regranex is specific for diabetic foot ulcers that are non-healing. Hyperbaric oxygen therapy is specific for wounds that are complicated by complex infections or wounds that are complicated by diminished blood flow, ischemic wounds. So those are the things we're going to talk about. Now let's talk first about what's involved in hyperbaric oxygen therapy. There's actually two ways to deliver it. One way is what they call a multi-place chamber. A multi-place chamber looks a lot like a submarine. So patients can be on stretchers, they can sit in chairs or recliners, and they will be breathing 100% oxygen by mask. The staff, in contrast, is just breathing compressed air. The other way to deliver hyperbaric oxygen therapy is to put the patient in a plexiglass chamber. And then the chamber is pressurized and filled with oxygen, so the patient's breathing 100% oxygen under pressure. So whether you use a multi-place chamber or a monoplace chamber, either way you get the same results. The patient's exposed to pressure across the entire system, and the patient's breathing 100% oxygen. Now, what happens in that situation when you're breathing 100% oxygen under pressure, it causes oxygen to be dissolved in the plasma. Now, how does that help? We'll go back to the fact that normally we carry about 97% of our oxygen attached to the hemoglobin on the red blood cell. And that means to get oxygen to the tissues, you have to have blood flow to the tissues. You specifically have to have red blood cells getting to the tissues, because the red blood cells have the hemoglobin that carries the oxygen. But if you expose a patient to hyperbaric oxygen therapy, they dissolve significant amounts of oxygen in the plasma. So anywhere the plasma goes, oxygen goes. So it's really an alternative approach to oxygen delivery, and we know you have to have oxygen to heal wounds. So if I have a patient who has compromised perfusion, I know they have narrow blood vessels. I know, or I suspect, that one reason they're not healing is that they're not getting enough oxygen to support the repair process. I know that there's blood going to the wound because they still have viable tissue in the wound bed, but there's not enough oxygen to support the healing process. That patient's very likely to benefit from hyperbaric oxygen therapy because now I can provide them with additional oxygen through the plasma. So even though I can't increase the number of red blood cells getting out to the wound bed, I can increase the concentration of oxygen at the wound bed by hyperoxygenating the plasma. So that's the end result. You hyperoxygenate the plasma and you provide additional oxygen to any tissues supplied by that plasma. So we've talked about how it works. Now, on your handout it says important point. I think this will make sense to you. If you have a patient who has a totally necrotic toe or a totally necrotic foot, dry gangrene, can you rescue that foot or that toe with hyperbaric oxygen? And of course you're saying no, and you're right. Hyperbaric oxygen therapy can promote healing of ischemic tissues, but it cannot rescue or resuscitate dead tissue, okay? It will not raise tissues from the dead, so it has its limitations. Now on your handout you have a list of the results of hyperoxygenation. You don't need to sit around and memorize these. I just want you to understand them. First of all, it talks about vasoconstriction, which sounds like a bad thing. It's like, aren't we trying to improve blood flow? How is vasoconstriction going to help? Well, you have to go back to the fact that ischemic tissues are chronically edematous because in the presence of ischemia, all the vessels dilate trying to enhance oxygen delivery to the tissues. Edema then develops because the dilated vessels allow plasma to leak out into the tissues. The plasma leaking out into the tissues further compromises oxygenation. When you raise tissue oxygen levels, then the vessels go back to normal size and edema is eliminated. So that relative vasoconstriction is helpful. We know that white blood cells have to have oxygen to kill bacteria. So if you provide that patient with hyperbaric oxygen therapy, you've tremendously increased the available oxygen, so you have essentially loaded the white blood cells up with oxygen, enhancing their ability to kill bacteria. So very important in controlling infection. Also, higher levels of oxygen help to push antibiotics across the bacterial cell membrane. So it enhances the efficacy of antibiotics, improves the bacterial killing effects of antibiotics. But of course, one of the major reasons that we use hyperbaric oxygen therapy is because the fibroblasts have to have oxygen to make collagen and all of the other connective tissue proteins. The keratinocytes need oxygen to reproduce and migrate. So frequently we're recommending a patient for hyperbaric oxygen therapy because we're hoping that will make the difference in getting that ischemic wound to heal. And we'll come back to that. So now you take all of that and you put it together and you come up with the indications for hyperbaric oxygen therapy. These are the patients you would refer to a hyperbaric oxygen center. And when you refer that patient to the hyperbaric oxygen center, they will evaluate the patient to determine whether or not he or she is likely to benefit from hyperbaric oxygen therapy, and of course they'll deliver the therapy. So the first is if you have a wound that is viable but hypoxic, so that could be a patient with an arterial ulcer. It could be a patient who has had previous radiation to that area because radiation damages the vessels and creates relatively ischemic tissues. So you'll frequently hear the term osteoradionecrosis. What does that mean? It means that radiation therapy can cause necrosis of the bone, but also the soft tissues. It increases the risk that you'll have a non-healing wound if you have a patient who in the past had radiation therapy, say to the chest wall following breast cancer surgery. And now they're undergoing surgery to that area. High likelihood that that incision is not going to heal because those tissues are relatively ischemic. But you can use hyperbaric oxygen therapy to increase the levels of oxygen in the tissue, get them over the hump in healing that wound. Hyperbaric oxygen therapy is widely used for patients who have had head and neck cancer, have required extensive radiation to the head and neck area. As a result, that entire area is ischemic. They'll have enough blood flow, enough oxygen to maintain tissue viability. But if there's any challenge, if they develop a wound, if they have to have dental surgery, they're not going to have enough oxygen to heal the wound. That's the advantage of hyperbaric oxygen therapy, to get them over that hump, get that wound healed. So ischemic wounds, patients with prior radiation therapy to the area so that you believe that that's why the wound is not healing. Also wounds with serious infections like necrotizing fasciitis or gas gangrene or chronic refractory osteomyelitis. Let me go back. I obviously should not have flipped that slide. You don't really have to worry so much about contraindications because the hyperbaric oxygen therapy staff will deal with that. Definitely a patient with an untreated pneumothorax, you're not going to pressurize them. There are certain drugs that are a contraindication. If they have severe chronic lung disease, that's a possible contraindication. If they're unable to equalize pressures, they will need to have tubes put in their ears. If they have severe claustrophobia, that is a relative contraindication that can frequently be managed with medications. Again, I want you to focus on indications as opposed to contraindications because your responsibility is to identify patients who might need and might benefit from hyperbaric oxygen therapy. And it's going to come down to two major groups, as we've already said. Patients whose wounds are non-healing because of some degree of ischemia, but who have enough blood flow to maintain tissue viability, and patients who have significant infectious complications. Those are the two groups you should refer to the Hyperbaric Oxygen Therapy Center for further evaluation. Once they go to the center, they will do tests to make sure that there's enough blood flow for hyperbaric oxygen therapy to be beneficial. They'll do a very complete history to identify contraindications and to address those potential contraindications. They'll take full responsibility for managing the patient in the hyperbaric chamber and monitoring. Now, you do have some responsibilities for the patient who's getting hyperbaric oxygen therapy, and that relates to topical therapy. This is particularly important for patients who are getting therapy in a monoplace chamber where the entire plexiglass tube is full of oxygen. Obviously, fire is a major hazard, a major risk. So we have to avoid any wound care products with an ointment or petrolatum base. So you would not use Xeroform gauze. You would not use Vaseline gauze. You would not use Adaptic. You would not use polysporin ointment. So you would very carefully review your topical therapy to make sure that there are no contraindications. Electrical stimulation, I'm not going to spend a lot of time on. Nurses do not provide electrical stimulation. Electrical stimulation is a modality that is very well understood by physical therapists. They do a great job with it. They know exactly how to place the electrodes to control the level at which the current runs. Hopefully, some of you are working in multidisciplinary teams where you have a physical therapist and you have access to electrical stimulation. I'm just going to briefly explain why electrical stimulation is sometimes used and how it is thought to work. First of all, they identified some years ago that healing wounds generate electrical current, and that if the wound plateaus, the electrical current goes away, and when the wound heals, the electrical current goes away. So that started people thinking, well, if a healing wound is characterized by production of electrical current, maybe we could use electrical current to get the wound back on track. And physical therapists have done a number of studies in the lab, and also they've done a great job of keeping records on their patients to document the potential benefits of electrical stimulation. You see them listed on your handout. In the lab, they were able to demonstrate enhanced cell migration, improved blood flow, increased white blood cell activity, and control of infection. And that has been supported by a number of clinical studies done by PT showing kind of a non-specific positive impact of E-stim on non-healing wounds. Now, Medicare will provide reimbursement for E-stim if the patient has not responded to standard wound care for 30 days. But you need to be working with a PT because they're going to be able to provide this modality safely. Again, if you've used E-stim for 2 to 3 weeks with no response, you're probably not going to continue. For any active wound therapy, your trial period is typically a minimum of 2 weeks, maximum of 4. The advanced therapy that we'll probably spend the most time on, and the one that you're probably most familiar with, is negative pressure wound therapy. The advantage of negative pressure wound therapy is that it's a general stimulus to repair. Specifically, it helps to move wounds out of the inflammatory phase into the proliferative phase by stimulating rapid ingrowth of new vessels and collagen formation. So those of you who have used negative pressure wound therapy, and that's probably most of you, know that if you initiate the therapy on Monday and you have a pale pink wound bed with no active granulation, when you come back on Wednesday, you expect to see a major change in the wound surface. You expect it to look dark pink, bright red. You expect to see evidence of active granulation. That's how negative pressure therapy works. So let's talk about how it's delivered and then the specific mechanisms of action. Then we'll talk about contraindications and some things to think about when you're using negative pressure wound therapy. First of all, you know that negative pressure wound therapy involves lightly filling the wound either with a foam or sponge-based product or with damp gauze, antimicrobial gauze. Sealing the wound with a transparent adhesive dressing, and then attaching a negative suction device that's connected to a pump. That negative suction then pulls fluid out of the wound and actually activates repair processes within the wound bed. We're going to go over that in just a minute. Now, with the foam-based products, you put the foam in the wound, you cover the wound with the drape, you cut a little hole in the drape, you apply what we call the track pad or active suction negative pressure device and connect it to the pump. With foam-based therapy, you protect the base of the wound with damp gauze, then you put your suction catheters on top of the damp gauze, more damp gauze, and then your drape. And then the suction catheters are hooked to the machine. Now, how does it work? Well, first of all, that negative pressure pulls out any excess interstitial fluid, so it actively reduces edema. And when you reduce edema, you improve blood flow. And when you improve blood flow, you significantly improve the rate of healing. One of the most important things it does is it actively manages wound fluid while maintaining a moist wound surface. So the negative pressure sucks all of the wound fluid out of the wound bed so that it's not sitting in the wound bed. And at the same time, the use of the transparent adhesive dressing keeps the wound surface moist. So it manages exudate, thus reducing the risk of infection, and keeps the wound surface moist to promote wound healing. The very most important thing that it does is it causes microdeformation of the cells in the wound bed. And it's like, what is that? And all they mean by that big word is, when you apply negative pressure against the cells in the wound bed, when that foam sucks down or that drape sucks down, then all of the cells in the wound bed are being exposed to that pulling force, that negative pressure. That force changes the shape of cells. So in my mind, because I have to have a visual, they go from round to like oval. You're thinking, so? Well, a very interesting fact is that if you mechanically alter the shape of the cells, it activates intracellular processes that are critical to the repair process. So that microdeformation of the cells in the wound bed is the most important mechanism of action for negative pressure wound therapy. And that's why we see a wound go from pale, pink, and smooth to actively granulating in a very short period of time. Now, I am betting that all of you have seen negative pressure wound therapy used on lots of patients. You've read lots of articles. You've probably talked to reps. You've probably seen lots of case studies and little glossy monographs. And so we start thinking that we have this extensive evidence base to support negative pressure wound therapy. In reality, we have limited controlled trials with mixed results. What we have is lots of anecdotal reports that wounds got better, even clinical series where they say, okay, we had these patients, we used negative pressure wound therapy, these were our results. But not very many controlled trials where we compare negative pressure wound therapy to another type of moist wound healing. So I just want you to be aware of that, because in most agencies there's a tendency to significantly overuse negative pressure wound therapy, and that's because everyone believes that there's all this evidence that the wound will heal much faster. But primarily the evidence is anecdotal and limited. And your responsibility to your agency, to your patient, is to use every therapy appropriately. I think every one of us in wound care is very grateful to have negative pressure wound therapy in our armamentarium, because we all have had patients who responded very well. At the same time, you want to provide input into protocols and decision-making pathways and other clinicians to prevent inappropriate use or excessively prolonged use. So let's talk about indications and contraindications. So indications, deep wounds, large volumes of exudate. Well, one of the things it does very well is to handle exudate. And especially if that deep, wet wound is nearing the end of the inflammatory phase or at the end of the inflammatory phase, but it's very slow to granulate. That's a perfect wound for negative pressure wound therapy, because it's going to handle the exudate, maintain a moist wound surface, and actively stimulate granulation tissue formation. It can be very helpful with surgical flaps, both pre-op and post-op. Pre-op because it helps to establish a very healthy bed that's granulation tissue that's very well vascularized, and that very vascular tissue is going to support healing of the flap or the graft. It's used post-op for flaps and grafts to eliminate edema, maintain good perfusion, maintain good adherence between the underlying wound bed and the flap or the graft. Fistulas we'll talk about later. We have very little evidence to support negative pressure wound therapy for fistulas. We all have had patients where we firmly believe that negative pressure wound therapy was helpful, and we'll come back to that. We're not going to really talk about that at this point. Large abdominal surgical wounds where there's high risk for compartment syndrome, again, because it manages the edema, it reduces interstitial fluid accumulation, it maintains perfusion. But there are definite contraindications, and I'm betting some of you work in agencies where no one seems to realize that negative pressure wound therapy is ever contraindicated. So you go back to, what does it do particularly well? What's it indicated for? It stimulates production of granulation tissue, ingrowth of new vessels, and production of collagen and other connective tissue proteins. It's not intended for moving wounds through the inflammatory phase. So if you have a necrotic wound, a wound with significant necrotic tissue, debride it first. I've heard people say, well, I can put down an enzyme and then leave the pump off for 30 minutes and then activate it. And I'm thinking, why? The wound's not even ready for negative pressure wound therapy. The enzyme's expensive. After 30 minutes, you're going to turn on the device, you're going to suck the enzyme away. That's what the wound needs, is a debridement modality. So if it's necrotic, debride first. If it's infected or you have bone infection, treat first. Never ever use it with a malignant wound, because you're not trying to support cell growth in a malignant wound. And this is the riskiest situation. If you have a wound where there are exposed vessels or exposed organs close to the surface, you have to use negative pressure wound therapy with great caution. Because if you put foam into an open wound that has only a thin layer of tissue between a newly grafted vessel or an organ like a loop of bowel, you know how the tissue becomes adherent to the foam and grows into the foam, and there's a significant risk that when you go to take the foam off, you could unroof that vessel or unroof that loop of bowel and create major bleeding, possibly death, or a major fistula. So you want all of your staff to know patients have died from inappropriate use of negative pressure wound therapy. Any therapy that has the potential to do a lot of good has the potential to cause complications. So you want people to be very careful and very appropriate with use of negative pressure wound therapy. If you're using this and you're using a foam-based system and there's a vessel or an organ close to the surface, you definitely want to use what we call a contact layer, like Adaptic or Mepitel, to prevent that adherence. Okay, so we talked about the significance of being cautious, being aware that there's potential complications. Also, you need to know that at this point we have no data to indicate that foam-based systems are better than gauze-based systems, that gauze-based systems are better than foam-based systems. So most clinicians select the system to be used for an individual patient based on that patient's needs and their experience with the different systems available to them. Now, in your handout, whether you're looking hard copy or online, you have a description of the different therapies. Let's see if I put it here. So looking first at back by KCI, because that's still the most widely used system. You know you've got the porous sponge that you're going to place into the wound bed. You want to cut it slightly smaller than the surface of the wound, the dimensions of the wound, so that the wound has the room to fill in. And then, of course, you're probably going to need to stack it if you have a deep wound, because you know that the foam is going to suck down, it's going to be compressed. Once you get the wound appropriately filled with the sponge, then you're going to seal it with the transparent adhesive dressing. You're going to cut a hole in the transparent adhesive dressing, and you're going to attach the track pad to the machine. You know there are 3 types of foam available, and as the clinician, you should select the foam that is best for that patient. The standard foam is the black foam, also known as Granufoam. Also available in Granufoam Silver if you want an antimicrobial effect. And then you have Versafoam, which is the white foam that's very soft and much, much less porous. And the white foam is very helpful if you have a wound where there's only a thin layer of tissue between the wound surface and vessels or organs, or if you're not sure how much tissue you have. White foam's a better choice because you won't get any ingrowth of tissue into the white foam. It is what should be used in tunneled areas. You never want to put the porous sponge into a tunneled area because you're not confident you'll get it all out and you could end up with a foreign body effect. So instead you would use the white foam for tunneled or undermined areas. If the patient has major problems with pain, white foam is better. Now, what about type of suction? You can use continuous or intermittent. The company recommends continuous for the first 48 hours and then switch to intermittent unless there's an indication for maintaining the patient on continuous. Now, one indication for keeping the patient on continuous is if they have high volume exudate, because intermittent is not going to keep up with the drainage. Patients who have a lot of pain associated with negative pressure wound therapy typically do better with intermittent because they're not exposed to the constant on-off, on-off. Now, gauze-based systems. Let's see if I put anything in about gauze-based systems. I did not. So just following your handout, there are several gauze-based systems out there. And of course, with the gauze-based system, one of the advantages is that there's less pain associated with that because there's much less tendency of the tissue to grow into or become very adherent to the gauze. So some clinicians will select a gauze-based system if the patient has been complaining of a lot of pain or is very sensitive, or if they're concerned about tissue adherence to the foam. There are other products out there and more coming to market. When you're on site, we'll show you a sample product that's intended for surface wounds that need negative pressure wound therapy for a short period of time. That's just peel and stick, no canister, and a very lightweight battery that attaches to the waistband. So we're going to have, going forward, many more options in the field of negative pressure wound therapy, all of which go back to the basic principles of managing exudate, maintaining a moist wound surface, and actively stimulating repair by changing the shape of the cells in the wound bed. Now, some of the considerations that we should be very aware of when we have a patient on negative pressure wound therapy and when we're educating our staff. These are the things I want you to really focus on when you're studying negative pressure wound therapy. First of all, you want to be aware this is relatively expensive therapy. It's $100 to $150 a day for most types of negative pressure therapy in most settings. Now, if you're getting really good results, okay, it's worth it because you're moving that wound rapidly through the healing process. But if you're getting very slow, limited results, you have to really rethink, is it worth that much money per day? Secondly, if you have a foam-based system and the seal is lost and the staff is unable to reestablish a seal within 2 hours, they have to remove the dressing and replace it with damp-to-damp gauze or with alginate or hydrofiber or an appropriate wound dressing, because the only mechanism for managing exudate with a foam-based negative pressure wound therapy system is the negative pressure in the canister. As soon as you lose the seal, you start to just trap wound fluid at the wound surface, and it becomes a swamp and tremendously increases the risk of wound infection. So you want your staff to know if they're having trouble on 11 to 7, they can't just turn it off and wait for you to come in. They have to remove it and replace it with a simple dressing until you get there. The biggest problem from a patient perspective, pain and bleeding, and we've talked about some of the things that you can do. First of all, you can put down a contact layer like Adaptic or Mapitel that is extraordinarily helpful because it prevents ingrowth of the tissue into the foam. So it tremendously reduces pain and tremendously reduces the risk of bleeding and tissue trauma. And it's so simple. But most of the time, you're the only one that will think about it. So don't be hesitant to use contact layers. Now, I've heard people say, well, won't that slow down the rate at which the wound granulates? I'm like, possibly. But if I'm ripping granulation tissue out every time I change the dressing, I'm slowing the rate of healing as well. And I'll take that slight slowdown in exchange for marked reduction in pain and marked reduction in risk of bleeding. Do not hesitate to use a contact layer. For some of us, it's almost routine to use a contact layer. The other thing you can do is you can use the white sponge instead of the gray sponge or the black sponge because, as we've already discussed, that prevents that tissue ingrowth. It makes a big difference. You can pre-medicate the patient before you do the dressing change. And the other thing you can do is you can tell the staff 30 minutes before I come to do the dressing change, I'm going to call you and I want you to go in there and turn the machine off so that fluid starts to accumulate between the wound bed and the sponge. Some clinicians will disconnect the tubing and instill saline or a saline lidocaine mixture to help lift the sponge from the wound bed and to deliver a topical anesthetic. The other things are pretty obvious. You're always going to protect the surrounding skin with something like Skin Prep or Cavalon or All Care or whatever you have. Obviously, you have a canister-based system. The staff has to change the canister when it's full. Always you follow manufacturer's guidelines. That goes across the board. Now, the other thing I wanted to talk about is discontinuation. What frequently happens is people get put on negative pressure wound therapy and left there, just left there. And that's very inappropriate. You want to think, what does it do and when do we no longer need it? Usual time frame for therapy is 2 to 4 weeks because what you're looking for this therapy to do is to move a wound from the end of the inflammatory phase into the proliferative phase. Typically, once you have a healthy bed of granulation tissue and reduced volumes of exudate, you can discontinue it and cross them over to moist wound healing. One of the things we tell people to look at is when you initiate negative pressure wound therapy, typically you'll see very rapid improvement in wound status. So you put it on Monday, you come back on Wednesday, you're like, wow. And Friday, that looks great. And Monday is like, wow, this wound is doing so well. And then within 2 to 3 weeks, it's like, yeah, it's a little bit better, it's a little bit better. It's still filling in, it's just not nearly as fast as it was. Once you hit that plateau, it's time to think about crossing the patient over to moist wound healing. So 3 indications, or 2 major indications, I guess, for discontinuing negative pressure wound therapy. One is if you're not getting the desired response. I've had patients come back, they've been on negative pressure wound therapy for 3 months with no response. That's crazy. So very poor response or no response, or very good initial response and now starting to plateau. Both of those are indications for discontinuation. What we say is we're going to give the patient a vacation. So we're going to take the negative pressure wound therapy off, cross them over to moist wound healing, see how they do. I can always start it back if I need to. I'm not really going to spend time on the cell proliferation induction system, Regenesis by Provan. It's not widely used. It's primarily being used for post-op pain and edema. It's not covered by Medicare and Medicaid, so I'm not really going to talk about that. It is on your handout. You can review it, but we're not going to test you on that. Same thing, non-contact ultrasonic therapy or MIST therapy. There is some early evidence that the ultrasonic waves can stimulate cell activity and cell migration and contribute to wound healing. But again, we currently lack strong data, controlled trials. So I'm not going to ask you that. That's there for reference and just to make you aware, because I think you will start to hear more about the use of ultrasound therapy, MIST therapy in the literature from your rep. So I wanted you to know that it is a potentially valuable advanced wound therapy. But I also want you to know that at this point we have limited data. Now the next thing, and we've only got a few more things to go, we're going to talk about human skin equivalents or bioengineered skin substitutes. You'll hear different terms. There is both a dermal replacement known as dermagraft or graft jacket, and there's a bilayered skin replacement, dermal epidermal, and that's apigraft. So we're going to talk first about dermagraft. All of these products, again, are indicated for wounds that are through the inflammatory phase, but having problems with the proliferative phase. Now, dermagraft or graft jacket is indicated for wounds that are slow to granulate. And what you have is you have a bioabsorbable mesh, and it's populated with human fibroblasts. So when you put that down into the base of the wound, you're providing that wound with several things. First of all, you're providing that scaffolding that allows the patient's own fibroblasts to begin to migrate, attach, reproduce, and produce collagen. But you're also bringing in additional fibroblasts, like a temporary workforce, to be of assistance in getting that wound back on track. So it's like, okay, here's your scaffolding. Oh, and I brought you in a whole crew of fibroblasts. Now, these fibroblasts are derived from neonatal foreskin, and they do not generate a rejection response because they do not express the HLA antigen. So they're like universal donor cells. So very safe to deliver. Also, there's growth factors. So what you've done is given three things to help: a scaffolding, a temporary workforce, and a stimulus to repair. Now you can see that it can be applied weekly for up to 8 weeks. Usually you apply it, you monitor the response. So if you put it on week 1 and they come back week 2 and it's looking really good, and the wound is beginning to granulate nicely, you might wait a week. If the wound continues to granulate very well, you might not need to replace it or to reapply it. But if after 2 weeks it slows down, then it might be time to reapply. Remember that it's very expensive. It's like $600 to $800 every application. So you want to make sure you're using it appropriately. But if it makes the difference in getting that wound to heal, it's worth the money. Now your apigraft, your dermal epidermal replacement, has both a dermal layer that's populated with fibroblasts and an epidermal layer that's populated with keratinocytes. This is essentially a non-surgical skin graft. So when would you use apigraft? Only for a superficial wound that fails to epithelialize, where you're trying to provide final closure. And you would use it as an alternative to a split thickness skin graft, so that instead of having to create a wound to heal a wound, you buy skin or replacement skin to heal the wound. So the dermal layer populated with fibroblasts, epidermal layer populated with keratinocytes, about $1,200 to $1,500 for a piece this size. Obviously, I do not have a sample. It comes in a nutrient broth. You have to have the wound ready for application of this skin graft, of this skin substitute. So it's not something you keep on the shelf. It's something you order If I'm going to place this on Friday, I'm going to order the product to be delivered typically on Wednesday or Thursday. I have to double check to be sure that everything is in order and that the replacement skin has been correctly nourished by the nutrient broth. I have to take out that little piece of replacement skin and cut little fenestrations or put it through a mesher because I have to have a mechanism that allows the exudate to escape. I don't want exudate pooling between the wound surface and my skin substitute surface, my appligraft surface, because then this will never take, okay? Absolutely critical to have a totally clean, very well vascularized wound bed with low bacterial counts. Because when I take this piece of skin out of its nutrient broth, cut my little holes, and put it on the wound, all of the cells in this graft are initially dependent on the blood vessels in the underlying wound bed for nourishment. Because I've taken it away from its nutrient broth, where is it going to get its nutrients now? And the answer is from the underlying wound bed. My goal is to maintain very tight adherence between the appligraft and the underlying wound bed so that the cells can get the oxygen and nutrients they need, and so that the blood vessels from the surrounding tissue can start to migrate into my graft and provide long-term nourishment. That's graft take. Now, when you think about the fact that this graft is totally dependent on the underlying wound bed for support, it's obvious that you have to have a clean wound bed. You cannot put appligraft on a wound that has slough, because how is this going to get nourishment through slough? How is it going to get ingrowth of new blood vessels if there's a layer of slough? If you have a highly exudative wound because of high bacterial counts, this is not going to take, because the fluid will cause separation between the graft and the wound bed, and the bacteria will destroy the graft. So you have to have a well-vascularized, clean wound bed. It has to be a superficial wound if you're looking at using appligraft. It's $1,200 to $1,500. You want to make sure you're using it appropriately. All of that is on your handout. Once you apply it, you want to maintain tight adherence either by using negative pressure wound therapy to pull the two layers together, or a compression wrap to push them together. Now, the next section in your handout is on split thickness skin grafts, and it's basically everything we just said about appligraft, except now you're going to create a donor site wound, and you have to take care of that donor site wound as well. Management of a split thickness skin graft, the actual graft site is just like managing appligraft. You have to have a clean, well-vascularized, shallow wound bed. You have to maintain close adherence. You have to create little fenestrations that allow exudate to pass through. All of those things exactly the same. The one additional concern is taking care of the donor site, which is probably the most painful element of care for the patient, because this is a huge partial thickness wound. So you want to keep that surface moist and protected. Contact layers plus gauze and wrap gauze, very good choices. Just don't let that surface dry out. Well, I'll just skip through a lot of things. Okay. And then the last thing, myocutaneous flaps. This is primarily indicated for your cord-injured patients who are wheelchair-bound, who develop ulcers over the ischial tuberosities or other weight-bearing surface. And the reason that myocutaneous flaps are frequently indicated is because we do not want those ulcers to heal with scar tissue, because if they do heal with scar tissue, the patient ends up with bone, scar, skin, and they're higher risk for breakdown than they were before the ulcer occurred originally. So instead, what we want to do is we want to rotate healthy, well-vascularized tissue to cover that bone. So myocutaneous flaps primarily used for our cord injury patients with full thickness ulcers on weight-bearing surfaces. What you want to think about is that literally what they do is they create a triangular flap in the tissue all the way through the muscle, and they rotate that flap to cover the bony prominence. They can do that in a spinal cord injured patient because even though they disrupt the muscle fibers, these patients are not ambulatory. So yes, if this patient was ambulatory, that would have implications, but they're not. So what we're doing is we're simply moving tissue adjacent to the bony prominence to cover the bony prominence. Now, in assuring the best chance for a take preoperatively, again, we want a healthy wound bed that's well vascularized. A lot of times they will use negative pressure wound therapy to create a very well vascularized wound bed. You also should be sure that the patient is nutritionally sound, okay? Because once you rotate that flap, you need to be able to make granulation tissue to seal that flap into place, okay? To glue that flap to the adjacent tissue. I read one article from a plastic surgeon who said if you send a patient or if you take a patient to the operating room to do a myocutaneous flap and that patient's malnourished, you've just thrown thousands of dollars down the drain because the patient will not be able to make the granulation tissue necessary to knit the flap into place. The flap will fail. Now you've just wasted tissue and wasted money. So we want to make sure the patient's ready. Clean, well-vascularized wound bed, and positive nutritional status. Then when they come back from surgery, we want to make sure that they're not exposed to pressure, shear, or friction, so we want them on a very high-level support surface. Some surgeons want them on air fluidized beds like Clinitron. All surgeons want them on air support surfaces with low friction covers, low shear covers, low volume airflow to keep that skin surface protected, dry, and to eliminate shear force and evenly distribute pressure. In our spinal cord injury center, if they do flap surgery, you will see these patients prone on stretchers, moving through the halls because the plastic surgeons don't even allow them to be on the surface of the flap. They want all pressure off, all shear eliminated, all friction eliminated until that has healed. The other thing that you see on the slide, and you also see it on your handout, you have to realize that the greatest risk factors early post-op are either ischemia or vasocongestion. Now, ischemia would be caused if you threw a little clot to one of the vessels that feeds the flap, and it would be immediately evident because there would be a change in the skin color and temperature of the flap. So, very frequent monitoring of skin temperature and color of the flap is critical because if they do throw an embolus, they have to go back to surgery and get that clot aspirated so that they save the flap. A more common complication is vasocongestion because when they do the flap, they typically use microvascular surgery to connect arteries within the flap to arteries in the surrounding tissue. And because arteries are thick-walled, you can do arterial anastomoses with pretty good results. But it's much harder to do anastomoses between veins in the flap and veins in the surrounding tissue because they're not nearly as thick. The walls of the veins are not nearly as thick. So sometimes what happens is you're getting good arterial inflow, but you're not getting very good venous outflow. And if you're not getting good venous outflow, then you get progressive congestion and edema. And then you leak fluid out into the tissues, and gradually the edema compresses the arteries and you lose the flap because it becomes ischemic. So you've got to manage the vasocongestion until the veins in the flap and the veins in the surrounding tissue are able to establish good anastomotic connections. That's usually 3 to 7 days. And what is sometimes used is leech therapy, because leeches do two things. They suck blood, so it helps to decongest the flap, but they also secrete an anticoagulant so that little leech bites continue to drain blood to keep the flap decompressed. It's kind of like maggots. There's the ick factor, but they're very, very effective. So sometimes we just have to help our patients get past the ick factor. Okay, that's the things I really want you to know about management of refractory wounds. And in our next session, we'll be moving on to leg ulcers. Thank you very much.